All right. So welcome. So today we're going to be talking about thyroid and neck ultrasound, which I'm personally very excited to get Judy and Tweed's opinion on a lot of this stuff. I know this is one of a lot of kind of controversies and just kind of diagnostic dilemmas for us in pediatric radiology. So we deal with a lot of things in this kind of general category. So the first thing I want to go over is just thyroid. That'll be kind of the first segment, and then we'll kind of dive into some other neck stuff as well. So first off with thyroid, I think it's just important to keep in mind that there's a lot of differences between pediatric thyroid cancer and adult. And I think that lead to a lot of challenges with us just because, like many things, that a lot of things are designed for the adult side, and we try to adapt them as best we can to the pediatric population. But I think there's just some real challenges with that we have to consider. So as far as just comparing pediatric thyroid cancer to adult, we know that nodules in general are much more likely to be malignant in pediatric patients. They're more likely to present with metastatic disease. But even despite both of those things, the mortality in these patients is less than that of the adult population. And then pediatric patients are also more likely to have genetic associations. And then, as I alluded to, a lot of the kind of reporting schemes that we'll kind of talk about in a minute here, but both the TI-RADS and ATA and some of those things, they really were designed for the adult population. So I think in our patient population, we really have a kind of a lack of a unified reporting scheme. It's really a challenge to know exactly what to do with these patients. So just to briefly review the kind of general reporting scheme, so we'll talk about ACR and we'll talk about ATA as well. So with ACR TI-RADS, I think this is probably the one that we're most familiar with. I think this is really nice and easy to follow, and I think that really attracts a lot of us towards using this. So that kind of has these general categories of these 5 things listed at the top here. Each one of those gets put into a category, and you get a certain number of points for each of those. And then those, depending on how many points you accrue, put you into one of these 5 different categories, which then kind of gives you some guidance on whether those nodules should be biopsied, whether they should be followed. And I think this is really, if you just Google ACR TI-RADS, this is one of the first graphics that pops up. It's really easy to find. And I think, as I said, it really kind of leads a lot of us towards using it. The main caveat I'll point out, and we'll talk about this in a minute as well. I think one of the main weaknesses with our patient population is that these size criteria, again, were developed for adults with fully developed thyroids. Pediatric patients have much smaller thyroid glands, so the thyroid nodules tend to be smaller. So I think directly applying these size criteria can definitely lead to some issues, as we'll talk about in a minute here. The ATA is, I think this is a lot more convoluted and difficult to follow. They include a lot. I think this is more so designed for clinicians. If you just Google the ATA guidelines, it's really hard to find a nice graphic that we can easily apply. This particular graphic is adopted from a paper that I'll discuss in a minute here. And you'll notice that they have this caveat that this is their interpretation of the ATA guidelines. It's really not clear, it doesn't have a nice thing like the ACR TI-RADS does where it's a graph. It's very easy to follow. They overall kind of support the adult guidelines for thyroid nodules, but the main caveat they give is that, as we mentioned, the characteristics and clinical context should trump the size. So just a few caveats about this. So they have some clinical factors that we don't always know about as radiologists. So for example, they say that all hyperfunctioning nodules are assumed that they're going to be surgically removed. So these guidelines really only apply to the non-hyperfunctioning thyroid nodules, which, as I said, right off the bat is difficult for us as radiologists to know whether they're hyperfunctioning or not. But otherwise, has much less stringent size criteria, so smaller nodules can still be FNA'd if they have some of these risk factors. The other thing I'll point out here, some of these, as we talked about before, these patients and our pediatric patients are more likely to have genetic predisposition syndromes for malignancy, which again, we don't always know about, but is a component of this particular ATA guidelines. But overall, the ATA guidelines have less stringent size criteria, but overall, I think it's just a little bit more unclear about how to follow this exactly. So there's been a few different papers that have been published about how these different grading schemes kind of perform in the pediatric population. So this first one, if we look at this, was just specifically for TI-RADS. So this chart on the left here, this is looking at the expected malignancy rate for each one of these TI-RADS categories in the adult population. So we can see that the lower ones, the benign and not suspicious, had very low risk of malignancy. If we compare that to how TI-RADS performed in the pediatric population, we can see that 1, 2, and 3 pretty much all have the same cancer rate. Every category had a higher cancer rate as compared to the TI-RADS. Particularly this last one has almost double. So we can see that the TI-RADS really, I think, underestimates the risk of malignancy in pediatric patients. And I think applying TI-RADS directly really leads to some issues in our patient population. The next one, so this looked at the ATA as well as the TI-RADS, and then also looked at some modified categories. So looking at these two, the TI-RADS 3 and TI-RADS 4. So this was looking at nodules that had a TI-RADS 3 scoring scheme, but no associated size criteria. So if you remove the size criteria, this is kind of the performance of those TI-RADS 3 and TI-RADS 4 categories. So overall, we can see that the ATA has a high degree of sensitivity, but very low specificity. So when we're talking about wanting to rule out malignancy, we want to make sure that we're not missing patients that have malignancy. So in this particular, we want to make sure that whatever we're using has a very high sensitivity. The highest performing one in this particular group was the TI-RADS 3. So if you had a TI-RADS 3 or higher nodule, regardless of what the size of that nodule was, that was 100% sensitive. And then the specificity of this category was a little bit better than the ATA. As we can see, as we already talked about, the TI-RADS has a pretty poor sensitivity, just TI-RADS without any size modifications. So overall, kind of this was their conclusion. So like we talked about, nodule size should be considered less, and then they recommend kind of a modified algorithm, but they don't specifically recommend one of these. And then this is one of the more recent papers that came out. So this compared ATA versus TI-RADS. So again, this was just using TI-RADS straight up without any modifications to it. So they have a pretty small patient population, but looking at ATA, they had 100% sensitivity. So they had no misses of malignant nodules. Compared to the TI-RADS, we had a few that were followed and one that was considered to be ignored. So kind of their final conclusion was that, like we talked about, the characterization and stratification of TI-RADS, I think, is attractive to a lot of us just because it's very easy to apply, but sensitivity is not good enough for what we're trying to use it for. So they recommend either using kind of that modified TI-RADS size criteria or using ATA. So all that being said, I'm kind of curious just to talk to you, Judy and Haitui, about, in a practical application, this is just a case that we had that, has a very, clear thyroid nodule in the right thyroid lobe here. If this came across your reading station, I'm just curious, what is your kind of personal approach to how you kind of describe and report on these nodules? Do you make specific kind of recommendations for, following biopsy, et cetera? Kind of how do you just approach thyroid nodules in general?
So we do what our endocrinologists want us to do.
Right.
We sort of had a discussion when the ACR TI-RADS first came out, and they have asked our group to use ACR TI-RADS, give a point value, but then they wanted us to basically cross the size criteria off of our recommendations list. So we have that graph with like X's put over the like biopsy if greater than this versus that for the 4 and 5 categories. I personally sort of will gestalt it based on the ATA classification system, and then also assign a TI-RADS score without recommendations to biopsy versus follow. The one caveat is we do have a special thyroid clinic that we have here, where it's just patients we know who have thyroid nodules either from here or referred from elsewhere for our thyroid clinic. So for those, I'll be a little bit more descriptive with regards to recommendations, like consider sampling versus not, versus ultrasound follow-up rather. The other thing I will just kind of mention is you can have a super suspicious thyroid nodule, but it's so small you can't physically do an FNA. So those are also like the kind of, I'm never sure exactly what to do when they're like probably a little bit too small to get a good sample of. So we have a standardized report. So with this one, I would give a TI-RADS score, go through all of the different point categories. Given the history of Dicer, I would say this is more suspicious given that history. Yeah. That's what I'd say about that.
Yeah, I think I'm similar. I mean, I have like a standardized template that has both like the descriptions and the, I guess, the scoring, but our endocrinologist, or at least to my knowledge, has not requested specific categories or scores. It's more of like a description. And then most of the patients, similarly, we have like a thyroid nodule clinic, and then there's one radiologist that's kind of responsible for like the conferences. And so those get re-reviewed, and then they just kind of discuss on a patient level basis to biopsy. So they actually kind of prefer that we don't, you know, go off and say recommend biopsy here and there, and then like let them decide. So in a way, it's good for me because I don't have to, I guess, struggle as much as you guys to kind of like come up with all these recommendations, but mainly just kind of describe everything and just have the information there for them.
Yeah.
Yeah, since you mentioned biopsy, our endocrinologists and pediatric ENTs don't want us to typically recommend FNA because they also might want to sample lymph nodes in the same setting for these pediatric patients. Like, so combine all of the sampling they may or may not need to do all at once. Yeah.
Yeah. We kind of have a similar pattern. So this is our a template. So we use TI-RADS as well, at least the kind of terminology of TI-RADS. We don't assign an actual score. So we use each of these 5 categories, and then in the pick list choices, these points are kind of just a reference for the radiologist to kind of know how suspicious that particular thing that they're assigning to that nodule is. But we put these in there, so we'll describe using it. I think it's really helpful, at least, to have kind of a unified terminology so that everybody's using the same language. And, you know, for follow-ups, we're not always, you know, saying different things about describing nodules differently. So I do think TI-RADS is very helpful from that perspective. We similarly have a kind of a thyroid clinic with ENT and endocrinology, and we've kind of gone back and forth with them about how to do this. So they see both adult and pediatric patients, so I think they're very familiar with, you know, TI-RADS in general, and I think they're familiar with this concept that TI-RADS is probably not great for pediatric patients. And they've asked us to still give a TI-RADS score with that caveat. But my main concern and what I've shared with them is that not all of our patients, you know, like you mentioned, Judy, not all of the patients necessarily go or are coming from that clinic or going through that clinic. You know, sometimes say we have a kid that comes in for, you know, palpable lump and ends up being a lymph node or something like that, and we just incidentally see a thyroid nodule and they're just being followed by their pediatrician. I've been concerned about that particular scenario of, you know, saying there's a, you know, a TI-RADS 1 or TI-RADS 2, and then the, you know, pediatrician might look that up and say, you know, oh, this is benign, or, you know, I don't have to be worried about this. I've been kind of worried about that particular scenario. So that's the main reason we don't specifically put a TI-RADS category in our impression. We kind of have this kind of vague, just thyroid findings that's above, and we kind of just leave it to them to, you know, because we use these categories, you know, the ENT and endocrinology can calculate their own TI-RADS score if they really kind of want to know what it is. I might change this a little bit in that particular scenario, like I just mentioned. If I know this is coming from a pediatrician or somebody who might not be as familiar with thyroid nodules, I might add a little bit more information to this. But that's kind of our general approach. I think it's not always very satisfying, but that's our kind of safe way of at least how we've kind of agreed. And I think, like you guys are saying, you know, a lot of this is going to be institution dependent, and, you know, depending on where a lot of your thyroid nodules are coming from and how they're being followed. But that's kind of our own institutional approach to it. And then a couple more cases. So this is a case that Judy shared with me. This is a patient, very typical appearance of Hashimoto's, so very kind of enlarged, heterogeneous hyperemic thyroid gland. Has this hyperechoic nodule. This is that classic kind of white knight nodule, this regenerative nodules of Hashimoto's. There's this and a couple other kind of specific patterns have been described as being very likely as being benign nodules. I'm curious if with this kind of nodule, do you modify how you report these? Do you say this is, you know, very likely to be benign, even if it doesn't necessarily meet, you know, specific TI-RADS criteria? Or how do you kind of report on this?
Yeah, the like classic lesions, I don't give a TI-RADS score. I describe them and then say, you know, like in this case, the so-called white knight of Hashimoto's thyroiditis, because those are supposedly benign universally. So that's what we do. And then, you know, things like other classic lesions, I don't assign a TI-RADS score, or I won't use the like exact descriptors unless I'm like trying to point them towards a diagnosis. And that way we avoid confusion, or like sampling things that don't need to be sampled.
Right. That makes sense to me.
You know, just a quick question for you guys,
Yeah.
out of curiosity. For all these Hashimoto's, like I feel like I see at least one or two whenever I'm on ultrasound, kind of like a follow-up. And, you know, it's always heterogeneous. I mean, there may be lesions, maybe pseudo lesions. I mean, how do you guys approach those where, I mean, do you try to describe every single nodularity that might be, or just kind of say like overall heterogeneous, not no true discrete lesion? Because sometimes I feel like we're not even following something that's real, but the technologist may put calibers on it, and then we may end up following it, and then we may or may not see it the next time. So it's really hard for me to report those specifically.
I
Yeah.
agree.
And I actually have a
I
case of
just,
that I was
oh, go.
Oh no, I
with
didn't
that
want
very exact
to.
question. So this is again, like you mentioned, this is one of those thyroiditis cases, and you like you're saying, just diffusely nodular. I really struggle with these for the same reason. Different sonographers might have different nodules that stand out to them. They might measure different things. I really have a hard time with these. Oftentimes, I personally will just say, I'll call it nodular heterogeneity, and I usually, in a case like this, I won't report discrete nodules. I think it's important if you have a follow-up to really closely kind of scrutinize, kind of scroll through the thinning side by side and make sure there's not a specific nodule that is changing in any way, that might lead you to think it's a real nodule and not just kind of this focal heterogeneity. But I'm curious to see what you guys think with these, what you guys do with these two.
Yeah, I don't go crazy with measuring every single nodule. I will definitely compare the nodules. And then I also think in these cases it's important to look for little microcalcifications, like ill-defined calcifications not in a nodule. Because like that might be something you see in these patients too. So unless there's like clearly a nodule that is different from all the rest, I just sort of lump it into a diffusely heterogeneous gland,
Okay,
kind of like you do, it sounds like.
I like that. Right. And then just going back a little bit. So a couple more nodule cases. So this is a 12-year-old, kind of came in with neck infection, kind of had this incidental nodule that was seen in the left thyroid lobe, had a thyroid ultrasound. So has this, what looks like a nodule. But I think this is where kind of just pattern recognition is important. So just recognizing that this has a very similar sonographic kind of echo texture is what we would expect the thymus to have. So then showing you another image of the thymus down here. So you can have ectopic thymic tissue that can be located either in or adjacent to the thyroid gland. So again, just kind of being familiar with what that pattern is, recognizing this is not really a true thyroid nodule, but is just ectopic thymic tissue. And Judy, I know you shared this case with me. Do you have
Yeah, just
anything else to add?
my residents are always like, that looks like PTC, it's PTC. And
Right.
typically it's a younger patient, not always. It can be a little bit of an older patient. And we still see that. We don't give TI-RADS scores for these because it sounds like you're describing PTC. So we just say intrathyroidal ectopic thymus and like leave it at that, especially if we're confident. Like almost always these patients will have ectopic cervical thymus elsewhere. Or you can kind of get a comparison look like through the suprasternal notch or something like that, just to like be absolutely sure that this kid still has like thymus elsewhere. And so it makes sense that this is yeah, it can be challenging, but it's like so like it's like that dot dash appearance and like homogeneously that way throughout. No like peripheral irregularity or contour irregularities or heterogeneity within that pattern inside of the nodule, if you will.
Right.
That's the best way I have to describe it to our residents. It's just like one of those ant minis you just got to know about in kids.
Right. Right.
Yeah, I find the ones that are inside the thyroid a lot more challenging
Right. For
sometimes
sure.
because like you said, it's like such a mimicker. But sometimes like your example where it's kind of at the inferior edge of the left thyroid, it's like in a classic location for that um like thymic extension, cervical extension, or ectopic thymus as well. So I think also knowing where it typically is most of the time when it does present is kind of helpful.
Right. For sure. All right. And the next case, so this is a kind of another one. This is just kind of an entity just to kind of familiarize you with this idea. So this is a patient that came in, had this nodule in the right thyroid lobe. This is the presentation. Then 13 months later, you can see that this has kind of shrunk down, has developed some calcifications within it. This is one where if you didn't have the comparison, if you only had this one, you might be worried about it with these kind of macro calcifications. But when you have this comparison, you can see how this has evolved over time. This is kind of the so-called mummified nodule. So sometimes these can happen either spontaneously or after a lesion gets FNA'd, and they can kind of bleed and kind of hemorrhage into themselves, and then they can evolve and kind of shrink down and get calcified like this. As I said, I think it's really helpful when you have a comparison just to see how this nodule has changed over time. When it kind of shrinks down and gets this kind of calcification like this, we can call this more of that mummified nodule. Don't necessarily have to be worried about this particular pattern. And again, Judy, I know you shared this case with me. Do you have any other comments on this one?
If you don't have a prior comparison to show you that it used to be a colloid cyst that now is this densely calcified nodule, sometimes when these patients go to FNA, if like somebody thinks they're suspicious, the cytopathologist will they will feel like really hard calcifications as they're trying to do the FNA, and then the results might not be as diagnostic because there's not like tissue that they can get typically. So kind of if that's the story you're hearing when you're looking at one of these nodules after it's been sampled and they're like, well, what do we do now? Do we take it out? Hemithyroidectomy or something like that. Just remember this entity. It's like, again, one of those ant minis that it's helpful when you have comparison, but when you see that super densely calcified nodule like that, think maybe this was a prior colloid cyst, not PTC. And sometimes additional follow-up may be helpful also to kind of show that it's not growing or otherwise suspicious over time.
All right. Then next thing I wanted to chat with you guys about, just kind of some protocol stuff. So, I mean, all this thymic stuff, or thyroid stuff, I think is pretty straightforward. One question I had for you guys is what scenarios do you look at all the lymph node zones? So we have a pretty extensive neck zone protocol. So these are kind of the three categories of, if we see a suspicious mass, if they come in for a thyroid ultrasound and we see something, then we'll default to doing the neck zones. If they specifically request it, so if it's coming from ENT or endocrinology and they have some suspicion, if they have some reason why they want the neck zones, and we'll do that if they specifically ask us to. Then any patient that has a history of thyroid cancer will default to doing that. So those are the three main times that we will always do the neck zones. I'm curious if you guys have a different approach, if you do it more often, or when do you guys look at the neck zones in addition to the thyroid?
I know when I worked at Texas Children's, we did the thyroid nodule mapping or nodal mapping specifically for thyroid cancer patients. I don't think it's automatically done like whenever you see a suspicious mass or like preferentially ordered by any particular MD or ordering services. But here at CHLA, I think we do neck zones for basically every head and neck. Yeah. And maybe because of that, the sonographers are faster at it. Maybe I should probably ask them how long it takes, but it's essentially in everybody.
Wow. For me, I don't want our techs to do lymph node mapping for everybody. Like if there's no nodule or it's like, oh, classic colloid cyst, something that's not cancer. I feel like little kids and teenagers always have lymph nodes. And so I'm afraid we're going to be like, oh, what's up with that lymph node? It's sort of funny looking or whatever, when there's like no chance that it could be a malignant lymph node. Like I feel like we see reactive lymph nodes all day, every day. So for our protocol kind of sounds like yours, Jeffrey, where it's if we find an incidental thyroid nodule that looks like it might be cancer, the techs should go ahead and add on thyroid cervical lymph node mapping, and that way they don't have to get a repeat prior to sampling, so they know which lymph nodes to sample. We also have people who will specifically request cervical lymph node mapping, and we do it even if the nodule is like not cancer. But we don't just routinely add on cervical lymph node mapping.
All right, that's our diffusely nodular case. We already chatted about that one. This is kind of a companion case to that kind of diffusely enlarged thyroid. This is another one. This is just to kind of familiarize yourself with the pattern of this particular entity. So this is a patient that came in with just kind of diffuse thyroid enlargement. There's actually in the ATA recommendations, they actually specifically recommend thyroid ultrasound in all adolescents that have diffusely enlarged thyroid glands specifically to evaluate for this particular entity. So I'll play through the cine clip here. So you can see that the thyroid is just diffusely abnormal. We have a bunch of abnormal lymph nodes down in the lower neck as well. This is just a longitudinal image, again, just kind of showing you that diffusely kind of enlarged and heterogeneous looking thyroid. This patient, as I mentioned, had multiple abnormal thyroid or cervical lymph nodes. So very heterogeneous, has some little microcalcifications within it, very hyperemic. So this is the diffuse sclerosing variant of papillary thyroid carcinoma. So again, I've seen a couple cases of this that have been passed over and just called thyroiditis. And again, I think this is just to be familiar with this particular pattern. If we compare this to that, prior case we looked at with just the diffusely heterogeneous and nodular thyroid, the overall kind of texture of this thyroid gland is just a little bit different. It's more hyperechoic, kind of has a speckled appearance to it. So again, just kind of be familiar with this, especially with these lymph nodes. It can be challenging when it's kind of just diffusely abnormal. There's not really a discrete nodule. It's really, I think, easy to pass it over, but I think this could just be a thyroiditis type picture. But again, just kind of being familiar with this idea that not all diffusely heterogeneous thyroids are always thyroiditis.
Jeffrey or Judy, like in these cases, have you guys tried using shear waves? Because I wonder if it would differentiate between like a Hashimoto thyroiditis versus like a sclerosing pattern of PTC.
We keep talking about adding strain elastography, actually, where you like push with the transducer rather than get ROIs with like just like absolute velocities. We've had a couple of different issues arise. So we've had several cysts, like when we were, just sort of playing with the strain elastography. The cysts, they were like classic cysts. They look super stiff for some reason. But I think that's a great idea to just go ahead and add that on. I think it can be helpful if the gland is like a lot stiffer than you would expect with but the problem, I don't know, I go back and forth because like if the whole entire gland is stiff because it's the whole entire gland is PTC, I don't know, I think maybe it could be helpful, and we keep talking about adding it to our nodule protocols and we just haven't adopted it yet. One day.
Yeah. Yeah, we're similar. We haven't formally started using it. I think it's definitely an interesting idea, but not something I have personal experience with. All right, so kind of shifting away from thyroid into some other next stuff now. I think in this topic we always have to talk about lymph nodes. So I think this is something like you mentioned, Judy. We see this all day, every day. I think it's a challenge, for me to know exactly what to do with some of these lymph nodes. So this is a patient that came in. I think this one we would all kind of be concerned about this. This is a very abnormal appearing kind of nodal conglomerate. It's very heterogeneous, hyperemic, doesn't really have that normal fatty hilum that we would like to see. This ended up being a patient with lymphoma versus this case I have here on the right. This is more of the typical appearance of, we still have that nice fatty hilum. We can see that vascular flow into the hilum. It's enlarged, but it's relatively homogeneous, so that, very much more typical look for reactive lymph nodes. I'm just curious to know your general thoughts on, I think there's a whole spectrum between these two kind of classically abnormal and kind of classically reactive lymph nodes where I don't always necessarily know what to do with those. What's your general approach to lymph nodes in these kids? Like, do you have specific criteria that kind of push you over towards thinking something is, not just reactive, or how do you approach these in general?
I hate lymph nodes.
Yeah.
So I hate measuring things, but in these cases, I will actually look at the short axis diameter, because if the tech has like a big field of view and you're just like, oh, it's a lymph node, but then you actually measure and the short axis diameter is like 2 centimeters, then I'm more likely to be like, okay, well, you guys got to work this up. But the morphology, like the heterogeneity, if we still see the fatty hilum, if it's more round compared to oval, like all those, typical features. But I agree. I think it can be very challenging, especially when we don't have any history. It's just like lump is all we get, or other. Like we have so many ultrasounds that are ordered with an indication of just other, and you have no idea what's been going on.
Right.
So we do ask our techs to get extra history, like is it growing, fever, blah, 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 all that good stuff, to help you like know clinically if it's probably reactive versus not. But we've been wrong. I have been wrong before when it's like, oh, probably reactive, and then it ends up being some crazy lymphoma or something. So I don't know. Do the best you can, I guess, is my life advice.
Yeah, I think they're hard because like you guys said, like there's always a spectrum. So because I guess for better or for worse, we literally sample every single nodal like level on everybody. Like I have kind of a sense of what normal sort of look like, and when they're kind of bilateral and symmetric, it's not too bad, or small. And then usually if it's enlarged and in more different nodal stations than just that one area that potentially could be infection, then I'm a little bit more worried. Yeah, of course, with all the different morphologies. And then if I feel like when the long axis and then the short axis like is big, like you mentioned, 1.5 or 2, and then even the long axis is like 3.5 or more, then I'm a little bit more concerned. And then in those cases, I would either say like follow up to ensure stability or resolution, and in a way, does not completely let it go. And potentially if they're um, kind of like a lymphadenitis, it could become suppurative or abscess. So it's not horrible if they do end up coming back and, having to not be cancer, but the infection gets worse. So that's
Yeah,
kind of
or
how
it's
I
like
deal with like really ugly looking ones.
or like atypical mycobacterial infection, like those nodes can look weird.
Right.
And like I think usually they do sample that. I think the old school teaching was don't sample. If you think it might be atypical mycobacterial, you shouldn't sample those nodes because of a risk of a draining sinus or whatever. But my ENT I have a pretty good relationship with our peds ENT, like main surgeon here. And he was like, those kids are going to have a sinus anyway because the infection's going to drain. So just sample it so you can titrate your antimicrobial therapy early. So I think that old school teaching maybe is changing. So I'm just like sample it if it's something they're concerned about, like when they have history, especially that's concerning.
Yeah, yeah, I agree. And my personal approach is I hate saying clinical correlation, but oftentimes with these, I'll say clinical follow-up. Just even if it looks reactive, but it looks a little funny, they at that point, these are superficial. They can palpate them. Clinical follow-up is pretty easy. They can make sure that they're kind of decreasing in size and resolving. If they're persisting over, months, or if they're getting bigger, then I think that should prompt a further workup. But a lot of times I will kind of default to saying, clinical follow-up to ensure resolution.
I should have sent you a case of this, but have you guys, especially with these super high frequency, like linear transducers, noticed that in some lymph nodes these days, you actually can see like the follicle zones in
Mhm.
these lymph nodes? Um, Whoever has a bunch of free time on their hands, you should write that up. Because I think if you see that, you can be much more reassured that it's probably a reactive, benign type of a lymph node rather than like lymphoma, leukemia, whatever.
Right.
So
Yeah,
please,
that is
please,
interesting.
somebody write that up.
I never saw that in fellowship, but I've seen several cases recently. I don't know if we're just looking closely, but it looks like you're saying, it looks like a little lymph node within the lymph node, those little kind of germinal centers.
It looks like that
Interesting.
pathological appearance. It's like a great rad path thing.
Yeah.
Give it to ARP, except it's like a normal case,
Yeah.
so kind of
Yeah.
lame.
And then another case. So this is a kind of just for more practical application of some of this stuff. So the adolescent that came in with weight loss and fatigue. So I'll play through this one city clip here. So has a bunch of big lymph nodes. So kind of maintain normal morphology, still have these fatty hyla. But if this was a toddler, this might not be as concerning, but definitely kind of a weird look in an adolescent. Left side again had very big kind of heterogeneous nodes on that side as well. I'm showing you some pictures of the liver and spleen as well, just to show you the liver was big and spleen was big. So this was one, that with this presentation, this could be neoplastic, this could be something like lymphoma. There's also overlap with, infectious stuff like mono. I kind of just, when I read this case, I kind of gave both as a differential. I'm curious, would you guys have done anything differently? How would you approach kind of a case like this?
I feel like your differential was pretty reasonable. Like, I mean, without any further information, it'd be hard to tell. I mean, weight
Yeah.
loss, I don't know if that goes a lot with infectious diseases, but I don't
think you
know.
can have that with EBV,
Can?
right? Like some patients, I don't know. That's where they got to get their labs. Like if you
Yeah,
look at EBV
exactly. So I was like,
titers, like
it could,
the IG whatever versus the IG whatever to know if it's an acute infection. I don't know.
Yeah.
I
yeah. And like blood smears. I mean, there's tons of things
yeah,
they
the
can
peripheral
do.
smear.
It doesn't have to be just us.
Right. Yeah, and in
Yeah,
particular, they consulted oncology and they did like the monospot, which I think is it was reactive, but that is not indicative necessarily of an acute infection. It just means he had mono at some point. So they're still following this, but I think this is likely going to end up being mono. But this was another one I just kind of struggled with in the moment of I like to be as
same,
specific as possible, but
same.
in this particular case, I just Like, you don't want to tell a patient they have cancer when they just have something infectious. But I think in this case, that's just part of our reality of kind of, working up and following these patients. So next
You
cases
know,
today.
that's another thing I noticed. I think the spleen there does look abnormal, but even with the linear probe nowadays, we can see the little nodules
Right,
in the spleen that seems normal. So
right,
it's getting harder and harder to differentiate,
right, for sure,
anti-variants.
for sure. So the next case, I like this case because this is a nice example. I really like to use color for lymph nodes, especially when we're looking for areas of separation or necrosis. So I'll play this cine clip here. So this is, pretty typical appearance of lymphadenitis. Has these chunky looking nodes, has a little bit of inflammatory fat stranding around it. But when we put color on, I don't think that node necessarily stands out as much. It's not, a clear necrotic fluid collection on the grayscale. But when you put color on it, when you see these avascular areas, I think that really kind of nicely helps to highlight areas that are potentially necrotic. Um, so I just like this example. This is, one of my attending the fellowship really kind of hammered this home that, if you put color on lymph nodes, it really just helps those areas stand out. Oftentimes, not that the whole lymph node is necessarily going to have color. A lot of times it is going to be more hilar. But when you kind of have this area that you can see the color kind of wrapping around this area, this ended up being a little necrotic area. And then just a companion case for that. So this is the MFI image. So it has this big, heterogeneous looking area, kind of difficult to differentiate. It looks like there's these kind of little specks of debris probably within fluid around this more solid looking thing, which is a lymph node. But when I put color on it, these MFI images I really like for lymph nodes. They really nicely show all of the vascularity of that lymph node. So we can see the hilum coming in here and kind of has this avascular fluid collection around it. And then on CT, a really nice correlate, just that kind of hyperemic lymph node with this kind of fluid collection around it.
Will you learn from my mistakes real quick? So
Sure.
I have overcalled like concern for necrosis or developing separation in the past, and but we didn't get good color filling because the kid was like crying, like a
Yeah.
screaming toddler. And so these days I try to like look in the tech notes closely, like was this kid screaming during this study?
Yeah, for
Because
sure.
almost always, especially from the EG, they're like losing their minds during imaging. So
Yeah, the color image is
don't
definitely.
make the mistakes I have made in the
Yeah.
past.
Yeah, and in a case like this, this is not necessarily something drainable, but they might. I don't know if this affects their duration of treatment or how closely they might follow them. Um, but yeah, definitely a good point that the color images can definitely be affected by patient cooperation for sure. So next couple of cases, this is just to discuss the kind of dilemma of dermoid versus thyroglossal duct cyst. So this is a patient has this kind of pretty homogeneous ovoid mass. So we can see the hyoid's been labeled here. Looks separate from the hyoid, has no color within it. This is the dermoid. So these often have this kind of so-called pseudo-solid appearance. So it's not truly solid, but just kind of has this junky debris in it. As compared to this thyroglossal duct cyst, so it has a very much more complex look to it. Has this kind of irregular track going down towards the hyoid here. I'll play this little cine clip for you here. So this is, as I mentioned, I mainly just wanted to discuss what your approach is to kind of differentiating dermoid versus thyroglossal duct cyst. I think it's important for us to try our best to do that, just because the surgical approach will be different. There's been a couple of different kind of grading schemes that have been proposed. So the Cyst score, which I have described here, and then the 4S score. Do you guys use either of these, or do you just kind of go by Gestalt, or what's your kind of general approach to kind of differentiating dermoid versus thyroglossal duct cyst?
Well, I think location. So we don't use like any specific scoring system, but we sort of use the like descriptions in the scoring system. So location is the money for me, I think, and then like the appearance of it. Um, yeah, oftentimes with like thyroglossal duct cyst, you might have a good history of it like kind of waxing and waning, where you don't have that history with the dermoid.
Right.
Yeah, location mostly, I feel like.
Yeah, I have seen this article, but have not yet implemented, the scoring system. So similar to Judy, and yeah, I just kind of like look at it and sort of, yeah, location, the deeper ones tend to be a little bit more of the thyroglossal duct cysts. Um, yeah, I don't know. Sometimes it can be difficult.
How about, do you have the patient stick out their tongue and see if the cyst moves at all? Supposedly that's described in the literature. I have found that to be useful like once, but we kind of knew it was the thyroglossal duct cyst. So I don't know. I don't know about that
Yeah,
one.
I haven't used an ultrasound. I know the ENT will use that clinically. Like I had discussed a case with one of our ENTs recently, and I had done an ultrasound. It kind of looked like a dermoid to me, but he said it was, moving when the patient was swallowing and sticking their tongue out. So he clinically thought it was more likely to be a thyroglossal duct cyst, but I haven't tried sonographically to assess that. But it is interesting for sure.
Yeah. The other thing my ENT told me is if we think it's a thyroglossal duct cyst, make sure we show the thyroid, because if they take it out, if the kid is the thyroglossal duct cyst, not the thyroid, if they take out the thyroglossal duct cyst because it's infected or symptomatic or whatever, they want to make sure that there is some thyroid there so they don't take out all of the kid's ectopic thyroid
Right.
that's in
And
the
that was
cell.
actually that discussion I had with ENT. That was actually why they called me, because I didn't mention that the thyroid was present in the normal orthotopic location, which we normally do, and we put that in most of our reports. But yeah, definitely include that in your report. Yeah, and we're similar to you guys. We don't use either one of these. I think we kind of internally use it, but we don't formally use it in our report. I mean, this makes a kind of a compelling argument that maybe we should. So they looked at, just people reading these ultrasounds as is, the specificity was only 4%, sensitivity was high, overall accuracy was only about 30%. Using one of these two categories, so they both perform pretty similarly to each other, but definitely seem better than just using our kind of gestalt. I kind of wonder, we have a very large group of, 20 radiologists that are reading these. If people might not be as familiar with some of the nuance of reading these, I wonder if implementing some of this might be helpful. So something I've kind of thought about when I was putting this together. But yeah, we're similar. That we're not formally using one of these.
Tell me if you guys change.
Yeah.
We'll stop you.
And then this next case, I put this in here just to make that same point that you just mentioned. So this is a patient that has this kind of ectopic thyroid tissue. So we actually have, as part of our soft tissue neck protocol, no matter what they see, they're always supposed to take at least 1 or 2 images of the thyroid just to prove that it's actually in the location where it's supposed to be. Even if they're doing like a lymph node or something else in the lateral neck, it's kind of challenging to say, if you think you see a thyroglossal duct cyst, then go look and make sure the thyroid is there. I think the more kind of layers you add to your protocol, the more likely they're not to be followed. So we kind of just have a standard part of our soft tissue neck protocol. Anytime you're looking at anything in the neck, just take a couple images of the thyroid just to prove that it's actually where it's supposed to be. So next topic I wanted to just chat about was vocal cord ultrasound. We just started doing this probably about 6 or 8 months ago, and it's been interesting. I think it's really been helpful. Our ENT group has really liked it. Before I get into a couple of cases, are you guys using vocal cord ultrasound, or have you thought about using it?
One of our ENTs asked me to, and like the conversation died. So I'm sure it will get brought up again one of these
Yeah.
days.
Yeah, at Texas Children's, there were only a select few, and one of the like main reader was or is a neuroradiologist. So I do not have a lot of experience with it.
So I'll just show you guys a couple of cases. I think it's been I think relatively easy to implement. And like I said, our ENT group has really liked it. Specifically in the patients that have congenital heart disease and undergo these extensive cardiac surgeries very early in life. It's pretty invasive to do laryngoscopy, and it's pretty easy, I think, to do ultrasound. I know that there are at least a couple places that are doing kind of screening ultrasounds for patients that have undergone cardiac surgery, just to kind of make sure they don't have any vocal cord issues, and kind of identifying that prospectively rather than waiting until they have symptoms and then potentially doing a laryngoscopy. So kind of the main thing we look for is the retinoid cartilage. So these kind of two hypoechoic rectangles right here. So the couple of measurements that we do, so we measure the vocal cord retinoid angle and then the maximum glottic angle. I personally am not the biggest fan of these measurements. I feel like they're very variable, like when different sonographers measure them versus radiologists. You can kind of make these measurements be whatever you want them to be. I personally go a lot more on the gestalt of, just visually looking at the vocal cord and seeing if they're moving symmetrically. So I'll play through this little cine clip here. So if you kind of focus on these retinoid cartilage here, so you can see as the patient's kind of breathing, as they're kind of crying. You can see they kind of come together nicely here, have very symmetric motion. So this is a normal case, and I think, again, just kind of nicely illustrates the normal anatomy. If we compare that to an abnormal case, so this is a still image just showing that there is asymmetry in the kind of position. So this one is more abducted, and this is more adducted. So as I play through the cine clip here, I think you can recognize that there's very clear asymmetry within the motion of the vocal cord. So the right side is, moving back and forth, while the left is kind of just hanging out there. It's not doing a whole lot. So again, when I read these, I'm more focused on the kind of symmetry between the two vocal cords rather than the actual measurements. And then this is kind of our reporting template. So this is the kind of normal values that have been reported for these different measurements. So as I mentioned, the maximum glottic angle, and then measuring that vocal cord and retinoid angle, both versus abduction and adduction. A lot of times I'll just delete this if I can't get good kind of reproducible measurements, or if they don't necessarily align with what I'm thinking just visually looking at the vocal cords. But overall, I think this technique has a lot of value. And like I said, our ENT group has really liked it. I'm trying to get them to do it more often because I think we're probably underutilizing it. But I think really I've enjoyed doing it. And I think it's pretty easy to implement once you kind of get an idea of what the anatomy is. And, like Twee, like you always advocate for, with volvulus ultrasound, adding it to other protocols. So if you look at, pylorus and intussusception, I think it's very easy to do something similar with this. So, we do a ton of thyroid and neck ultrasound in general. I asked the sonographers to just for practice, kind of look at the vocal cords on those other exams, just because it's a lot higher volume than, waiting for everybody to get trained on these dedicated vocal cord ultrasounds. So I think it's pretty easy to kind of implement in practice just by kind of modifying some of your other protocols and just kind of looking at it in that way as well.
Can I ask a dumb question? Does this stuff change with age? Like, can you do this at any age?
It's definitely more challenging. So as they get older, so we had a 32-year-old that underwent a heart transplant, and they asked us to do a vocal cord ultrasound in her. It's definitely more challenging once you start getting calcification within the thyroid cartilage and all those other kind of laryngeal structures. That particular patient, I would say it's very hard to see the retinoid cartilage discretely, but I think we could still see the motion of the vocal cords pretty well. So it's definitely harder definitely as you get into adulthood, but I think most of our age kids, especially the neonates, I think it's much easier.
Thanks. Interesting.
And then kind of another just technique I'm interested if you guys are doing. So this is a patient that came in with pharyngitis, and we were asked to do we don't formally do tonsillar ultrasound, but we just kind of incidentally, our sonographer picked up on this and took a few images of it. So this is the tonsil here, right, subjacent to the submandibular gland. I'll play through the cine clip here so you can see one side here, base of the tongue is here. This is the other tonsil here. I'm curious if you guys are using tonsillar ultrasound in any way.
We don't have a formal protocol, but there has been requests from the ED every now and then to look at the tonsils. And we kind of just do something similar to that. Although I have found that our linear probe does not penetrate as well. So I would have to use like more of a curved just because of our machines. But yeah.
We've been asked to do like a handful. So I think we have a protocol. More importantly, a couple of times we've picked this up incidentally on they're asking about abscess versus lymph nodes versus whatever in the necks. And you can see this area on the cines incidentally. So we had at least a couple of cases where we're like, hey, they're go look at the peritonsillar abscesses. So.
And then in those cases, do they then ask for a CT? Okay.
Maybe they are still
like, what value am I adding?
Yeah.
This is the thing. I'm like, if we are doing a CT afterwards, which all of them have gone on to CT so far, I have a hard time. Like if it's not going to change their management, why are we doing it? So
right. Yeah, this is just to show you the CT correlate. So those tonsils were abnormal, so you can see they're kind of just diffusely enlarged. No discrete abscess, so this was just kind of a tonsillitis without complication. But just to kind of show you the CT correlate to that same ultrasound. There's not a whole lot of literature that I am aware of. I think there's more on the adult side, but they're doing more transoral with the transcavitary probes that go into the mouth, which definitely are much more challenging to do that to a kid. But I think the technique, so they kind of, this is where they place the probe. I think everybody is familiar with looking at the submandibular gland. If you look just right to deep to that, you'll see the tonsils down there. Then this is kind of a similar image to the cine I showed with the tongue here, and then the tonsils back behind it. So I don't know. I think it's, and this particular paper suggested that it could potentially replace CT. I've talked to our ENT group about this, and they have been a bit skeptical. I think there's just not a whole lot of literature out there about it. I think, technically it seems like it's, relatively easy to evaluate, but, as you guys said, I think we just need a little bit more literature and kind of support to show this actually works and that it could potentially replace CT. And then a couple more cases. So Judy had alluded to this earlier. So this is the toddler that came in with a neck lump. The physical exam, I think, is always worthwhile to look at in these particular cases. So it has this kind of violaceous discoloration of the skin where this lump is. I'll play through this little cine clip here so we can see this kind of decompressing into the skin surface right here. So this is a very typical look for this nontuberculous mycobacterium. This is one of those ones where I think it's just worth being familiar with. It kind of has this Aunt Minnie appearance to it. So it has this kind of necrotic appearance. They oftentimes don't really have a lot of inflammatory fat stranding around them, which can differentiate it from other forms of lymphadenitis. Having the clinical kind of correlation, knowing that it looks like this, most often these will have this kind of purplish discoloration to them. And I have a nice companion case as well. So this, our sonographer put this in their tech notes, which is super helpful. This is the little lymph node down here, and then it has this kind of big necrotic collection that's decompressed into the more superficial soft tissues. Again, I'll play through this little cine clip for you here. So again, doesn't have a whole lot of inflammatory fat stranding around it, but has this necrotic collection that oftentimes will kind of drain superficially. So I think this is just important for us to be familiar with. I think oftentimes these will go undiagnosed for a long period of time. They'll try to, treat it with antibiotics, which are not going to be effective. So I think we can really add value with just being familiar with this entity, just being familiar with the kind of sonographic appearance to it. So again, these are both cases of this non-tuberculous mycobacterium. The next case, so this is a kid that came in with recurrent cheek swelling. So again, this is kind of an unusual diagnosis, but again, I think it's just one that's worthwhile for us to be familiar with. So this parotid gland just looks diffusely abnormal, has all these hypoechoic nodules throughout it. If we look a little bit closer, we'll see that some of these nodules have associated calcifications with them. I think the history is really helpful in these kinds of cases. This is not just a run-of-the-mill parotitis that we sometimes see out of the ED, but these kids that have this recurrent episodes of parotitis, and again, it has these associated calcifications. So this was a case of a juvenile recurrent parotitis. So again, just kind of being familiar with this entity. All of these hypoechoic nodules are kind of these pockets of salivary gland secretions that get kind of locked in there. So that's kind of what is the correlate to what we're seeing on here. But again, in case of juvenile recurrent parotitis. Then another case, so this is a 2-month-old that came in with cheek swelling. So it has a very abnormal looking parotid gland. So the left is very enlarged. It's relatively homogeneous in appearance, but definitely asymmetric compared to the other side. Very hypervascular, pretty much diffusely throughout that whole entire gland. So these can be a little bit of a diagnostic dilemma. Oftentimes these will get called parotitis. I've seen a couple that we kind of passed over and just called parotitis. That's kind of what happened in this particular case. They started this kid on antibiotics. They did another ultrasound about a week later. We can see that the parotid pretty much looks the exact same, still kind of pretty homogeneous throughout. Doesn't really look like it has a lot of inflammatory change around it. And then just kind of diffusely hyperemic throughout. So at this point, they kind of started thinking a little bit more, what else could this be? We don't really think this is parotitis anymore, definitely unusual, especially in a kid of this age. So this kid went on to have an MRI. So we can see that there's kind of this very T2 hyperintense, hyperenhancing mass, just kind of replacing the majority of the left parotid. So this ended up being a infantile hemangioma within the parotid gland, which is kind of one of the more common tumors of the parotid in infancy. So again, I think this is one of those cases where it's just worth familiarizing yourself with kind of the appearance and the fact that this entity exists. I think this can be differentiated from parotitis just because the overall appearance of the gland is pretty homogeneous, and it's oftentimes when we have parotitis, it gets more hyperechoic and looks more inflamed. Just visually looking at this doesn't really look particularly inflamed. So I think this is one where we can, raise the possibility that this is something else besides just, infectious parotitis. And then this is kind of an unusual one I just wanted to share with you guys. This is something this patient came in with a neck lump, and our sonographer just kind of incidentally picked up on these little cystic areas within the thyroid cartilage. And I am saving you guys some time from having to Google it and figure it out like I did. But this, I'll play through the cine clip as well. You can see these little cystic areas throughout the thyroid cartilage there. So this has been described. This is just a developmental variant. They're not really sure exactly why this happens, but sometimes it has a kind of male adolescent predominance that, I think the more often, if we looked for this more often, we would see it more commonly than we do. But this is just kind of this developmental cystic change within the thyroid cartilage. The kind of hypothesis is that this happens because of as the thyroid cartilage is kind of undergoing that kind of development and ossification, that kind of, for whatever reason, they get these little cystic changes within there. So if you see this, you can just call it a developmental variant. You don't have to worry about some, weird tumor or something like that.
Yeah, I've heard this called enchondral ossification of the thyroid cartilage. Yeah. It was really challenging in a kid who had a thyroidectomy. And so we were like, oh my God, is this recurrence? What is happening? But yeah, I agree. This is like one of those you just got to know about.
Right.
They can look scary.